is Dr. Chandrasekaran. Say hi.
Hi.
So Dr. Chandrasekaran is a consultant ophthalmologist from ISAC-KL. He obtained his Master of Medicine in Ophthalmology from University Science Malaysia. He has a subspecialty interest in cataract and refractive surgery and has taken part in numerous cataract camps in Malaysia, performing high-volume cataract surgeries. Dr. Chan's passion for telemedicine in ophthalmology has driven him to develop several medical creative innovations and has won many awards locally and internationally. Our second speaker is Dr. Gan Eng Hui. Dr. Gan achieved his Master of Medicine in Ophthalmology from University Science Malaysia and his Glaucoma Fellowship from MOH and National University Hospital Singapore. Dr. Gan is currently a consultant ophthalmologist and glaucoma specialist attached to ISAC-KL as well. He is well known for his expertise, especially in managing complex glaucoma cases. He actively participates in general ophthalmology and glaucoma conferences and is frequently invited as a speaker for both locally and internationally held conferences. Both our speakers have keen interest in sharing their experience and teaching the younger members of the ophthalmology community. So before we begin, I would like to announce that questions are welcome. Please post them in the Q&A section below. You can find the icon below the panel. The speakers will reply to your questions once they are done with their presentations. I have also posted instructions on how to join our Young Ophthalmologist group under the chat section, which I'll do again because I think it's already missing. And I would like to welcome those who are interested to join us. Finally, before I pass this virtual floor on to our first speaker, let's observe a moment of silence to honor the memory of Dr. Ahmad, a passionate and skillful ophthalmologist, as we know, and a glaucoma surgeon who departed this earth yesterday. Thank you. So Dr. Chandrasekaran, you can start your presentation now.
Okay, I'll share my, thank you, Dr. Sudha, for the kind introduction. Welcome everyone to our first webinar. I will start my presentation. So, the title, Eye Surgery, A Twist in the Plot. Well, a twist in the plot is always nice in movies, but it's not nice to have it during surgery. So especially when you're doing surgery and after op. So what we have here is actually, I will be presenting surprises on table, where these are all recent surgeries that I did, where when I encounter some surprises during surgery, Dr. Gan will be discussing about his cases, surprises post-op. So I have 3 cases here, and Dr. Gan will have 2 cases actually. So I'll start off with my first case. No financial interest to disclose. My first case is actually a 61-year-old Chinese lady, a Chinese-Indonesian lady. She has underlying diabetes and hypertension for the past 3 to 4 years. She came complaining of left eye blurring of vision to 3 to 4 months gradually. And she mentioned that 1 year ago, vision was very good and the vision is equal on both eyes. So on examination, the left eye, the vision was only 260 with pinhole of 624. On refraction is -522 with a -1 of seal. And the best corrected vision is 624 only. The anterior segment is actually is very shallow AC, grade 0. The lens is stable and is about NS2+ with no phacodonosis noted. The IOP was 26 on the left eye and the cup-teeth ratio of 0.7. The right eye, actually, it looks quite normal, except that the anterior chamber is slightly shallow as well. It's grade 1 to 2, IOP of 22 on the right. The cup-teeth ratio is actually 0.5. I have a refraction done. The previous spectacles, actually, she has a spectacle card that says there 2018 December. And if you notice the left eye, about 2018, that time is actually minus 1.5. And in short period of 1 year plus, it becomes about 500. So there's a shift of 400 within the 1 year. So do notice that this is the biometry of the patient. The axial length is actually almost similar. The ACD on the right, it's 2.9 is okay. The left eye is actually very shallow, 1.92. Okay, so there's no astigmatism in the eye, but very, very minimal. So if you look at the scan, this is very shallow here. On the right eye, it's actually quite okay. This is the pentacam of the patient of the left eye. The back is actually quite thin at the left eye, the back surface. Basically, this is to show the angle is actually very shallow in the left eye compared to the right. Okay, this is actually the Humphrey visual field of the patient. It's actually normal on both eye, almost okay. Yeah, and let's start the first poll. Basically, this is to just have some fun. Sudha, can we have the first poll? Yeah. So you can actually vote which one you think the diagnosis is, and we shall see which one is the diagnosis later. Oh, the host and panelists cannot vote. I just noticed that. So we give it like 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Can stop it. Can we see the result later or now? Oh, okay. Right. Anyway, I will continue. A lot of people say that it's actually a lens component here. Very good. So I actually thought it's a primary angle closure initially. And then the differential diagnosis is actually an anterior subluxated lens with a high IOP. And it could be a left eye amblyopia because the cataract is almost similar on both eyes. And just slightly more on the left eye, sorry. And I think it was Formulae keratoconus as well. So I planned for a left eye phaco and then the next day, because this patient is from Indonesia, he's going back the day after, she already told me anyway. So she has some monofocal lens, planned for a monofocal lens with no toric lens needed. And it's not for multifocal lens because of glaucoma. She actually wanted a multifocal lens. So this is the surgery. Basically, once I've done my incision, I put in the viscoelastic. I'm going to pause it here. You can see that the lens actually shallow. It comes to the front and there's no more AC actually. So can we start the second poll, Sudha?
Yeah.
Oops.
Okay, wait.
Here comes the second poll. Let's see what you guys are going to do.
I'll allow the panelists to vote if you want.
No. So what would you do at this point? Are you going to convert it into ICC and put in ACIL? Convert this into ICC and put in a scleral fixated lens later? Or continue with phaco, put in a CTR and IOL? Continue phaco and put in a 3-piece lens? Just stop the op, find someone else to do it, which means just refer. Okay, we can vote, so we just vote. Okay, I'm going to count to 10 again. 10, 9, 8, 7, 6, 5, 4, 3, 2, one. Let's see what people do.
Okay.
Wow, a lot of people would do the same. Very good. No one going to refer it. Good. Everyone is very confident, a very good surgeon here. So anyway, I'm just going to continue. What happened is basically put in the viscoelastic again. I do a CCC. I do notice that during the CCC that the lens is actually the zonal from 12 o'clock until about 4 o'clock here. So I'm just going to fast forward. Once I've done the hydro dissection, notice that it has gone worse. I try to phaco a bit. Once I have done a bit of phaco, I notice that when I start to, even the normal phaco, it's actually pulling the lens away. So I think it's not going to be stable. So my decision is to put in another viscoelastic again and to do a further hydro dissection. And I put in a iris hook to basically hold the lens into position so that it's more stable when I do the phaco emulsification. I'm just going to skip all this. So I continue phaco. The problem is when we do this kind of phaco, it's that one thing is that the area of weakness is the area where the weakness, the zonulolysis is. So you should have minimal movement. Try not to push the lens down. If not, the vitreous will actually come out and it cause a lot of trouble after that. So basically, I did complete the whole phaco without vitreous loss, and then I plan to put in the capsular tension ring so that the lens is centered. You try to put in the capsular tension ring as late as possible. Some people prefer to do IA first and remove all the cortical matter, but for me, I prefer to be safe. So it's difficult to remove the cortical matter after you put in your CTR because you are sort of pressing on the cortex matter after that. So I'm just going to skip all this. Once it's all done, I just put in a single piece lens and then it's all done. Okay, so day one post-op, the vision actually came back to 6, 7.5. The IOP was just 14. The patient is actually very happy, but I have yet to see the patient after day one because Malaysia was locked down after that. I mean, there's an MCO after that. So the lesson here is that a shallow AC, you usually will think of angle closure or there may be a lens component actually. To do the surgery, I would recommend to have iris hook at all times and to stand by your capsular tension ring. And the problem is we are unable to dilate and evaluate this patient. So we have to sort of judge it ourselves, or if you have a UBM or anterior segment OCT, then you can do a proper diagnosis. And how we actually see this patient here that he's having a lens component is that there's a sudden change in the refractive error, if you notice, which I already mentioned in the beginning of the whole presentation. So this is actually very important pre-operatively so that you know what are you going to look, what you're going to encounter in the on the OT table. Just for the junior doctors, ectopia lentis means there's a dislocation or displacement of the crystalline lens. And the dislocated lens means that the lens is completely outside the hyaloid fossa, meaning the lens is actually in the anterior chamber or in the posterior chamber. A subluxated lens means it's partially displaced, but it remains within the lens space. The problem with the phaco in a weak zonule is that there is actually a dehiscence somewhere, so the lens moves quite easily. And it's actually a very difficult CCC. Sometimes you have to have a counter traction to do your CCC, and phaco is slightly difficult, and the lens placement may be decentered, and the vitreous may actually prolapse from this big zonulus area. So when do you use a CTR? You use the CTR when there's a localized zonular dehiscence in less than 4 o'clock hours. And if you have a generalized or mild to moderate zonular weakness in cases such as pseudo-X and also hypermature cataracts. So there are some prerequisites for the CTR is that you must have a intact CCC. If you have a radial tear CCC, then you shouldn't be using your CTR. There shouldn't be any posterior capsular tear, meaning no PCRAN. And if you have more than 4 o'clock hours of severe generalized weakness, then you should put in a CNA ring. When do you insert a CTR? Like I said just now, as late as possible. You can put it earlier, it's safer. It's more of a stable maneuvering when you do your phaco, but it's very difficult to remove your cortex. And if it's late, it's easy to remove your cortex, but it's a bit risky. So don't delay too much, as it may further compromise your nucleus management. This is what I mean by difficult to remove the cortex. Just want to show, if you have a CTR in the back, okay, it's sort of like compressing on your cortex area. So when you pull the anterior cortex, you will notice that you're pulling along the capsular tension ring. So what you need to do instead is to pull below so that it clips off from below top. You have to find a way in between here so that you can pull it from below. If you're pulling up here, you will just notice that your CTR is just pulling and pulling, but you're not really achieving anything from here. Just a minor tip. So I have a second case now. It's a 26-year-old barrister. He just came back from the UK 6 months ago. He has chronic eczema. His skin is actually very red all over the body. He has multiple drug allergy and a long-term steroid as well, both oral and topical. He complains of left eye blurring of vision for the past 1 year, which has worsened over the past 2 weeks. So his vision on the left eye is actually counting finger. That was within really just 2 or 3 weeks that he mentioned. And he's unable to be able to refract because it's already a mature cataract. On the examination, there's superior lid trichiasis. The cornea is mildly dry, and I can see that it's an intumescent cataract. There's no cells yet. IOP was 17, and the fundus, there's no view. But B scan is all good. So he noticed that the other eye is still a 6/6 vision. The refraction is minus 500. But the refraction of his left eye, he told me that it's about the same as the right eye. There is also a mild cataract on the right eye as well, a very mild PSCC. So this is the B scan. The axial line was entered via immersion. It's almost the same. Basically, you notice the lens thickness is actually very much thicker than the right. Sorry, ACD is slightly shallow. There is astigmatism on the left eye compared to the right. Okay, so this is confirmed by 3 scans, actually the pentacam and also the autoref. So we plan for left eye toric IOL. It's a monotoric IOL. 1 week later though, the patient wanted a multifocal lens as well, but I told him no because of risk of glaucoma. And actually it's a poor biometry results, which may be inaccurate. It's also an intumescent cataract with a shallow AC. It's of high risk. And he also has a risk of post-operative prolonged uveitis because of multiple drug allergies and all. So this was the planned area of implantation. So this is the case. We'll start it off. Oops, sorry. Basically, I use a viscoelastic and vision blue and all those. I hyper inflate it And then what I did is just aspirate the middle so that to decompress it, because it's an intumescent cataract, I always do this. I do it in multiple areas actually. Try to decompress as much as I can. And then I try to do my CCC. So the thing about doing CCC in intumescent cataract is if you take a look here, there's Argentinian flag that happens. It just tail on its own. So let's start the poll. Sudha. So what are you going to do now? Are you going to convert it into a ECCE and put in a monofocal IOL? Convert this into a ECCE and put in a toric IOL? Still continue phaco and put in a monofocal IOL? Or continue to phaco and put in a toric IOL? Or are you going to get help from someone else and do it for you? So I'm going to count again. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Let's see the results. Okay, very good. Most of you are going to put in a monofocal IOL. Some are going to get help. Some continue phaco, put in a toric IOL. Some are going to convert to ECCE. Okay, very good. So I'm going to continue. So what I did was I make an extra, I further decompress it at the area of the Argentinian flag. I make an incision at the anterior capsule. And then I continue CCC on the other way. Basically try to be as fast as possible, as try not to extend it again. I have decided to go on with this is actually just IA. It's not a very mature cataract because, like I said, it's only a 20-over-year-old man. It's not going to be a very hard cataract. So I continue to just IA it. You don't really have to phaco anything. No phaco power is needed. But setting is actually reduced to a very low setting, and basically completed the whole surgery without a fuss. And so I have decided to put in a toric IOL that was already planned. But during the incision of the IOL, I noticed that, and the leading haptics are all right. This is actually a plate haptic, but notice that there's a tear at the IOL, so it won't be stable. I've decided to actually pull this out. Yeah, a series of unfortunate events. Basically, the IOL broke. To pull it out again. Fortunately, I have a backup lens, which is the same power, so I put in the same one again. So this leading haptic is actually already in the bag. So you have to be really gentle rotating the lens and try to just ease it in. Basically, you look at this is 100 at 101. I have a Varion with me, so I know that it's I don't have a marking there. So, but it's based on the Varion digital marking. So I didn't dare to use a IA to remove the viscoelastic that was remained. So instead, I Simco it out, and basically it's quite stable in the back. I did everything without a suture in the end. Okay, so the post-op day one is actually the unaided vision is 67.5. The final refraction was actually 0.5, 0.25. The patient does have headache due to anisometropia. His the other eye was minus 500. So either he does a LASIK, ICL, or contact lens, but I think the best for him to do is just to use contact lens. Currently, he's actually just using contact lens. His IOP has been stable. However, there was prolonged inflammation for the next 3 months during the MCO time and all. Anyway, he's happy with his vision now. So we just continue with his contact lens. Lesson number 2 is that in young intermittent cataract, it imbibes water. Like I said, the patient actually just have this blurring of vision within 2 weeks. It's a very, very fast progression. To me, do not delay the surgery. Just do it as soon as possible to prevent the Argentinian flag. To prevent Argentinian flag sign, overfill the anterior chamber with viscoelastic. That's the most important thing. And for me, I do a puncturing like this now using a straight needle and decompress areas everywhere actually. And the other one that you can do is to puncturexis, where you actually put your phaco into the segment removal mode, straight away puncture the middle one, the middle of the capsule, and decompress the lens actually. Or the other way is to do a small rexis and enlarge it as it goes. For me, this one doesn't really work, and the puncture rexis as well. I tried both. It would just extend anyway, but it's actually a way to do it. So how do you phaco Argentinian flag cataract? Only attempt if you are certain that you have no exterior extension. Just now, actually, it's a slow extension. I think it's not really posteriorly extended. That's why I proceed with it. And the cataract is not too hard. This is a very soft cataract. So very, very confident that it will be okay. And you have to lower your setting. And you may need to do relaxing injection at the anterior capsule. Okay, case number 3 is a 51-year-old businessman complaining of blurring of vision for 1 year, both eyes. He's unable to read without the reading glass. His vision is N14 on both eyes, which is very bad. And he has requested for a multifocal lens for reading for reading of construction plans. He's actually a construction boss, so he has no known medical illness. His vision on the right eye is 6.9, left eye is 15, 6.9. He does have a little bit of cataract. The refraction on both eyes, that's hyperope, and his IOP is 17. Basically, he's fine, a normal cataract. So I plan for a left eye phaco. This is the video of it. It's basically a very routine cataract. Nothing much to shout about. So I'm just going to forward all this. Nothing wrong, nothing wrong. Phaco all done properly. IA is all done. So what happened is right here before the lens insertion, I put in the viscoelastic and watch. There is a sudden jerk movement. That is due to the viscoelastic. The right cuff is not really in position, so I would say that it's my fault in a way that I didn't check how tight the thing is. So I have a PC ran right here. So Sudha, can we do the next poll? So the next poll will be up. Would you do a vitrectomy and put in the AC IOL? A vitrectomy and put in a monofocal IOL and put it in the sulcus? Do a vitrectomy and a monofocal lens in the back? Or are you going to just continue with a multifocal IOL? Okay, anyway, I noticed that the PC ran is at this area. This is how it looks like. So I'm going to count to 10 as well. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Let's see the results then. So most of you would do a vitrectomy and put in a monofocal and sulcus lens. And monofocal in the back. Oh, okay. And monofocal with vitrectomy with multifocal. Very brave people. So we're going to continue. So what happened is I do notice that the PCRAN is just at this area. I can still see that it's actually folded here. So what I did is I put in some viscoelastic and open up the bag properly. I actually tried to do a posterior capsule. Well, it's basically a posterior CCC to stabilize, make sure that this is actually got stable PCRAN. If it is a linear one, then it's probably very difficult to do. Since this is like, it's already halfway there, I think I can just pull a very nice posterior CCC and complete the whole thing. So the end, it was quite round. I was quite happy with it. So I proceeded with a multifocal toric lens, which is trifocal lens. And I dial it into position. And basically, I still do some, this is actually by Simco, so that I don't have much pressure going into the eye. I still put in some triamcinolone to check if there's any vitreous in the AC. There was, so I did some vitrectomy as well, and in the end sealed the wound. So this is day 1 post-op. The vision is 6/9 on day 1. It's actually quite in the center, nothing wrong with it. This is actually 1 month post-op. I proceeded with the right eye anyway 1 week later, and it was uneventful. Thank goodness. This was the final vision. Without specs, it's actually 6/6 and can put up to N5. So PCRAN is if the PCRAN is small, you can actually convert it into a posterior capsulotomy. And you need to do vitrectomy if there is vitreous prolapse. That's why you need to check with triamcinolone. Good thing is that you don't get PCO post-operatively, but the risk is that you may get a lens decentration or IOL drop during your surgery. Cataract surgery is a routine, usually uncomplicated procedure in the skill of a hand-skilled surgeon. Very rarely, a complication may arise, which may be managed optimally, can still yield excellent results. This picture is just to show that our idiom, the sepandai-pandai tupai melompat. You may still fall. You may fall the other way around, but if you manage it properly, you may fall nicely though. So thank you for your attention. Thank you. I'll pass it to you, Dr. Gan. So I'm going to end my screen here. Okay.
Thank you, Jambon. Okay, so I should start my presentation. First of all, I would like to thank Young Ophthalmology Group to invite me to this session just to share 2 of my cases recently. Okay, why it is, sorry, So as Jambon has mentioned, he was talking about intraoperative surprises, where I will be talking about post-operative surprises. So I'll be sharing 2 cases here. The first patient is a 36-year-old gentleman with preoperative history of high myopia in both eyes. And the best corrected visual acuity at the time was actually 6/6. And however, the patient is a known case of primary open-angle glaucoma, but just a newly diagnosed open-angle glaucoma on single anti-glaucoma eye drops. So because he would like to wean off his glasses, so and ask doctor's advice, and it was planned for an ICL implant actually. For our junior doctor information, ICL is actually implantable collamer lens, which is actually stands for implantable collamer lens. Collamer means that collagen polymer. So it is actually a lens, a very soft lens to put between your lens and behind your iris to correct your refractive errors, can correct your myopia, hyperopia, or astigmatism. And the patient had an uneventful ICL actually done. However, he was referred to me for raised intraocular pressure trend in the right eye post-ICL, which occurred in about a month time. So the intraocular pressure at the time was 30 millimeter mercury with maximum medical therapy. Upon examination, it was found that this is actually the right eye. So the ICL was in situ. So there are actually numerous pigments can be seen at the endothelium, but it is not shown well in the photos. And when I did the gonio, I can see that there are heavily pigmented angle structures. So the trabecular meshwork also densely pigmented, and there are a few Sanique strands actually seen. But the angle is still open, it's not closed totally by the PAS. So at this point of time, I was thinking about pigment dispersion because of this ICL implant. So it was advised to explant the ICL because of intractable glaucoma control. And post-ICL explantation, the patient developed a mild cataract actually after that, and the intraocular pressure remained high, which is range about 26 to 28. And at this point of time, the gonioscopy showed that the angle was wider. However, it's still heavily pigmented. And at this point of time, even though the patient is on oral acetazolamide, the pressure still remained high. And he was listed for right eye phaco IOL with augmented trabeculectomy. And the indication for the surgery was cataract with suboptimal intraocular pressure control. Uneventful surgery was done. The intraocular pressure range quite normally post-operatively. However, it started to show increasing trend 1 month after trabeculectomy. The right eye trabeculectomy actually failed only after 3 months, despite multiple injection of 5-fluorouracil given, and together with needling as well during the session. Subsequently, right eye Barrett glaucoma implant was implanted. At the time, the IOP was 30 millimeter mercury with oral acetazolamide. The indication obviously is because of uncontrolled IOP. And post-Barrett implant, the IOP was under control. However, he still needs 2 anti-glaucoma drugs. So his final unaided visual acuity in the right eye achieved was 612, still 6.6 with ICL in situ in the left eye. And the latest IOP, which was measured 8 months after the Barrett implant, was 40 millimeter mercury, but he needs to be on 2 anti-glaucoma. With the IOP control, it is a good thing for the patient. However, the visual field progresses. As you can see from this visual field printing, this was the Humphrey visual field before trabeculectomy, but after trabeculectomy, the visual field has progresses actually quite a lot. So maybe we can start our poll, Sudha. Unexpected refractory glaucoma post-ICL implant. So what has been going wrong? So could it be because of non-satisfactory placement of the ICL? Or could it be because of poor preoperative assessment? Or it is just not a good candidate for ICL in the first place? So we'll give about 10 seconds as well for the answer. Is it okay to see the results now?
Yep.
Okay, majority of you say that this is not a good candidate for ICL. Okay, let's see what are the discussion after this, and probably you will find which is the most correct answer. So there are a few mechanisms of raised IOP post-ICL implantation. It could be either retained viscoelastic steroid responder, or a patient with a pre-existing glaucoma aggravated by any intraocular surgery, or it could be malignant glaucoma, angle closure, or a pigment dispersion. So actually all these causes has been reported in literatures, and I'm going to discuss a bit on this angle closure and pigment dispersion. So ICL actually can induce angle closure in different ways. So it can be either pupillary block or non-pupillary block, or it could be a combination of both mechanisms. So for pupillary block, it can occur basically because of an imperforated PI, a very small PI and block PI. And usually for ICL implantation in the using the old model with no central aperture, after the procedure, the surgeon actually should do a peripheral iridotomy to prevent pupillary block. So in case the PI is blocked, then pupillary block can happen. And pupillary block also can happen in a new model ICL with a central aperture if the central hole is blocked by viscoelastic. The non-pupillary block mechanism, it can happen due to inadequate space in the posterior chamber. And sometimes the oversized ICL can cause excessive vaulting of the ICL and cause further crowding of the angle. And it can happen due to inappropriate position of ICL as well. Sorry, there's a spelling error here. And sometimes over the time, non-pupillary block angle closure can happen when the patient starts to develop cataract and the cataract thickness is getting thicker, and it can cause a non-pupillary block angle closure as well. So UBM can be a useful tool to assess the anatomical changes over the time. As we can see from this UBM picture here, so there is actually a direct contact between the ICL and the posterior surface of the iris. This is because of the inappropriate position of the ICL and cause excessive shuffling of the iris and cause a lot of pigment release into the anterior chamber. And you can see here, the yellow color line actually show that the inappropriate position of the ICL. So this type of thing actually can happen post-ICL implantation. If you have a UBM, it could be or anterior segment OCT, it could be a very good tool to delineate the position of the ICL. The high IOP post ICL can also be related to excessive trabecular meshwork pigmentation. As you can see from here, I've listed a few studies here which reported trabecular meshwork pigmentation post ICL implantation. Some of the patients will have a pigment dispersion, but they never have raised intraocular pressure. But some of them, the intraocular pressure just raised transiently, but a few of them will actually need to be managed medically, and some might even need trabeculoplasty or trabeculectomy. But so far from the literature, we haven't found anybody which need glaucoma drainage device as in our patient discussed just now. So the points to learn here, first point, we need to have a meticulous consideration and pre-operative assessment before we want to implant an ICL for the patient, especially look into the absolute contraindication and also to assess the angle structure properly before the implantation of the ICL. And patients should be informed about the long-term risk before surgery, and to be advised to maintain on regular follow-up, even an uneventful ICL implantation, because the possible complication can happen probably years later as well. And during the follow-up period of time, the patient should be monitored for increased intraocular pressure, should be monitored for angle changes and pigmentation post-surgeries. Okay, I'm going to go to the second case. Second case is a 46-year-old lady with high myopia and history of LASIK done 20 years ago. So she actually complained of blurring of vision for the recent few months, and the unaided vision for the right eye was 6.7.5, left was 6.12, with a little bit of nuclear sclerosis seen. However, the optic disc and macula looks healthy. So she wished for a cataract operation. She's not keen to wear glasses for distance, but because she's a post-LASIK patient, I've actually had a long sharing session with her, talking about the benefits and the risks for multifocal IOL. So after the discussion, she finally decided not for multifocal IOL, and she just want to have a clear distant vision without glasses. So I'm actually planning a monofocal IOL for her, and her pre-op refraction was about 250 myop in the right and 300 in the left. So this is actually due to regression after the LASIK procedure 20 years ago. So this was the biometry before the operation. As we can see from the printout here, so the figures are actually quite normal, and there's no something abnormal or striking us, apart from she has a history of LASIK procedure done before. So in regards to choosing which formula is the best to select to calculate the IOL power, I decided to choose Barrett True-K at that point of time. So there's a reason behind why I choose Barrett True-K, which I will discuss later on. So she had an uneventful left phaco IOL, and post-operatively, the vision was bad. She only can see 648 in the left eye, and after a week, she only can see 645. And I've checked everything. Everything is in place. The lens is not tilted, and there's no cornea abnormality. There's macula is also okay, and she just cannot see well after the operation. And actually, I've refracted her earlier on, about 1 week. So her refractive status is about -1.25. So this is actually a refractive surprise which occur in a post-LASIK patient. So actually, at this point of time, we will discuss about what we can do for this refractive surprise. And obviously, if she brave enough to go through several other operations, other procedure that we might consider is probably a lens exchange early on, which probably we have to adjust the IOL power and explant and re-implant to the same eye again. But of course, this is not without the risk, and I've actually discussed in lengthy with her, and she decided to accept this condition. Okay, I think this is very important. That's why pre-operative chair time is very important in this type of patient, because I've already warned her refractive surprises, and although it is occur, at least the patient is pre-warned about this, and that's why probably because of that she is more easy to take it and willing to accept it. Okay, so we go for the second poll question. So refractive surprises. So what has been going wrong? So is it because of inappropriate IOL formula use, or is it because of inaccurate biometry, or lack of pre-operative keratometry assessment like pentacam, OpScan, and other things should be used. So we give another 10 seconds for the participant to answer the questions. Okay, let's see the results. Inaccurate biometry. Okay, so okay, let's see how is the thing go after that. Okay, on the initially I choose Barrett True-K for post-LASIK patient because it is published in the literature saying that Barrett True-K formula was either equal or better to other methods available for eyes with previous myopic LASIK or PRK. So that's why that's the reason why I use Barrett True-K for this patient. Okay, but because of the refractive surprises, I didn't trust Barrett that much already. So we actually have done several post-op analysis for this patient, and we use actually before operation we also use several methods to calculate. But finally, I decided Barrett True-K. But when we look back again, when we use this Z-cal to calculate the IOL power, if I implanted a lens power of 75 at 17.5, which is the lens I use for this patient, the refractive outcome will be minus 1.74, which is very close to the post-op refraction. So, so bear in mind, so although it's published saying that Barrett is so-called the best or could be more accurate, but sometimes in different patients, different condition might happen. So because she accepted that the left eye is not accurate, so she wished for the right eye cataract operation. So at this point of time, I will have headache again because I need to decide which lens power that I need to put in for the lights for the eye again to prevent the refractive surprises again. So I actually repeated the biometry for the patient. Actually, as you can see from these two biometry, this was the first one, this was the second one, and you can see that there was actually not much different. Both scan, the figures is only varies minimally, but if I compare these two scan image results, actually the imaging, I mean the clarity and everything, it's better in the first scan. So I still stick to the first biometry results when I do the second eye. And then for calculation, if I use a Barrett True-K, so this is the lens power suggested, but because of the patient has a little bit of cornea astigmatism, and I think my surgery actually induced the astigmatism more. So that's why I need to put in a toric lens for the patient for the second eye. So the suggested toric power is actually 1, and the IOL power is 17.5 for the spherical equivalence. But at this point of time, I also look back into my Z-cal, which predicted the first eye more closely compared to True-K. So it suggested that I have to use the lens of 15.5 sphere and 1.5 seal, which is about 1.5 diopter different between two formula used. Finally, I choose Z-cal for the second eye. So after the operation, the patient was very happy because she can achieve 7.5 vision unaided, and this made her no need to use glasses after the operation. So the points to learn for this case is, Actually, for post-LASIK patient, the surgeon is actually need to decide on several methods of IOL calculation, because there are many formula available in the market now for us to choose. But as I said, there's no single best formula to use, although some published literature claim that Barrett's probably at this point of time is still the best. So we actually need to have a consensus of several methods by computing the average power or go to the medium recommended IOL power to be used. It means from each formula, they will be suggesting IOL power. So we will take the median power. From the lower to the higher, we will take the median power. And when there is a wide range, if the range is too wide, it's recommended to hedge in the direction of myopic result. You will choose the power to render more myopic rather than go to the hyperopic side. And the third point is, even with the use of many specialized methods, the predictability of refractive outcome of our cataract surgery in patients with refractive surgery, laser refractive surgery done before is still not as good as the virgin eye. So that's why the refractive surgeon probably should consider providing the patient with preoperative refractive surgery, keratometry, and refraction, because this will help them for the cataract operation later in life. And therefore, patients who have previous refractive surgery should be warned about the potential need for refractive correction again after their uneventful cataract surgery. So that's why chair time before the operation is very important. And remember, always under-promise the patient, but over-deliver to our patient in those patients with post-refractive surgery done. So just for sharing, these are actually multiple methods to obtain the keratometry for patients with post-LASIK or refractive laser done. But I think probably we should discuss all these methods in a next session in more detail. And these are the formula available for calculation of IOL post-refractive surgery eye. That's all for my presentation. Thank you.
Thank you, Dr. Gan. Would you like to answer the questions in the Q&A session? Maybe you can just answer live.
How should I go back to the Q&A, right?
Yeah, the Q&A.
All right.
Yeah, you have two questions there.
Okay, Dr. Gan, for your ICL patient, have you considered performing a trabecular meshwork irrigation or aspiration? There are now devices for that. What do you mean by meshwork irrigation and aspiration with device? Is it are you meaning MYGS? But I'm not sure who is the attendees. So, but for MYGS, I won't consider MYGS in this case, because I can see that the pigmentation is too much, and then there are also peripheral anterior syndicate there. So I don't think MYGS will be a good method to bring down the pressure. Will Pentacam help in the fifth case? Oh, okay. So yeah, that's why sometimes Pentacam actually, I think Pentacam should be done for post-LASIK patient, maybe to look for ectasia or those things. But the actual problem in this patient, I think more likely is the IOL formula used rather than the keratometry, because as we can see from the first case and the second case, actually the surprises is not on the cornea itself, on the astigmatism itself, but rather because of the spherical power. So I think Pentacam, yes, is necessary, but probably It can help in terms of IOR calculation, of course, but it also need to be done just to rule out cornea ectasia, all those things, post LASIK surgery. What do you think, Jambon? Maybe refractive surgeon can discuss this better.
To me, actually, Dr. Gan used the IOL Master 700 TK, the total keratometry. We actually use the both anterior and posterior curvature to calculate the real using the Barrett True-K formula. It's actually both calculated using the machine and online. Somehow it actually came out to be different when we put it. Usually it's the same. In this case, Pentacam actually wouldn't help because look, it's going to be the same anyway. You're using the posterior K as well. So like Dr. Gan say, it doesn't really matter with the K thing. It's more of the, actually what happened is this patient has a regression in the there's myopic shift back to minus 200 or something like that. That may have caused that to me. So if you have no regression and then you're going to do your cataract, your cataract surgery, you should be okay. But somehow there's a regression here. I do not know whether that takes into account, but I think it does. So yeah.
Regarding the first question, it's the attendee said that it's not MIGS. There's currently a new instrument called transcannular gonial wash. I'm not aware of this, and I have no experience in this also. So probably you can share a bit of, maybe not in this session lah. So that's why I
if you want to speak, you can allow you to speak. Take up your hand and then we let you speak. Is that all right? Then there's someone take.
Cannular gonial wash.
You want to let him speak? Let Tannen speak.
Anybody in the attendee or participant heard about this? Maybe we can discuss a bit on this as well. But I think all these new instruments sometimes, because the problem is lack of evidence-based, post-op effects. So yeah, but it's good to know that there is this new instrument. So, but of course, for this case, maybe it's not so suitable because it's still new, and then we are not sure how about the outcome. But it's always good to learn about new things, and probably we can polish our problem-solving skill later on with additional new instrument.
Then you can actually speak. Just unmute yourself and speak. You want to unmute yourself? There's a button somewhere to unmute. Right-click yourself, or since you can share about this transcannular gonial wash. I've not heard of it as well. Do you think during IA time you can just wash it like that? Probably no.
Yeah, because I don't think so, because because this is combined with a cataract operation. So I definitely will do IA for the patient. So if I can dislodge and suck out all the pigment, it will be good.
Of course you would.
And then of course if that help, then I don't think my trabeculectomy will fail, right or not? Because
right.
If IA can suck out all the pigment and reverse the condition, why after the operation the pressure is still not well controlled?
One comment is that actually this case we shouldn't even be doing the ICL in the first place because the patient has underlying glaucoma. So you would just worsen it. Yeah. So this is the thing that should have been done.
Yeah.
Okay. Do we have any other questions then? Okay. Sudha, do you want to add it then?
Someone,
Oh.
there's another attendee who wants to say something. Palani Chami.
Oh, okay.
Do you want to unmute yourself? Yeah.
Can't hear. Still mute, I think.
Can you hear me?
Yep.
Yes.
The patients, cataract patients with the LASIK done, would they be, what do they prefer? Do you prefer monofocal or multifocal? Can you hear me?
Yeah.
Yeah, but not
So
so
can you
clear.
repeat the question, please?
Yeah.
The patients who have already cataract patient with the LASIK done, would they prefer monofocal or multifocal?
Jambon, you want to answer this?
Yes, actually it depends. It really depends on the patient. What we usually do is we do the chair time, the counseling thing. We tell the patient that, look, we can do this for you, but how confident are we to put in a correct lens for you? In a normal patient, we are almost at least 90% sure that whatever lens we put in is going to be the correct power. So you don't need to wear specs after that. But what if it is a post-LASIK? It reduces to about 70-80%. And with the multifocal in, you only have that 70-80% chance that you're going to hit the correct power. So if let's say the patient does have some power, then you may need to wear specs. But if let's say that with all the new technology, with the IOL Master 700 DK and all those things, it only raise up to about 80-90%. It won't be up to a 90% like original. If the patient is keen, it's actually the patient's decision to put in a multifocal or a monofocal. You can put in a multifocal still, but I would put in the EDOF lens instead of a trifocal or something like that. So I hope that answers your question.
Okay, thank you.
Yep.
Okay, any other question?
Oh, there's
All right.
a link about...
Yeah, so if none, then...
Yeah, okay.
Yeah, I thank the speakers for the interesting cases, Dr. Chan and Dr. Gan. I also thank all the attendees for attending this talk on a Saturday afternoon. So thank you, everybody. So that's it.
All right.
That ends
Thank
our
you,
surgical
everybody.
webinar.
Bye, thanks.
Bye.